Invite the first speaker, the President of Indian Neuro-Ophthalmology Society, Dr. Navin Jayakumar. He's going to talk on when and what neuroimaging.
Good afternoon. The topic I was given is about 8 minutes of when and what of neuroimaging. And because at 7 minutes, just let me know. I'll cut it short. So the goals of today's talk is to describe some uses of CT, what are the different MRI sequences and protocols, and when can we deploy them appropriately in different clinical situations. So I think CT still has use, although a lot of us just talk about MRI, most importantly in orbital disease. In trauma, for example, here you can see bone window CTs, and you can see the details. You can see the fractures of the medial wall and the floor very clearly because CT images bone well. And not only does it image bone well, it can also show you the interior bone structure, as you can see in the red arrow as an example. By way of contrast, this is how a normal CT would look, where the bone is entirely white. And this form of imaging, where you can image just the bone part of it, is called bone window CTs. Also used very commonly is osseous lesions of the orbit. For example, here is fibrous dysplasia. You can see that big white patch there on the CT plane, but you can see the interior of the bone here on the bone window. And 3D CT is also useful, not only in this situation, but in craniofacial dysosseosis to plan surgeries, etc. One very common use of CT is strokes, where you can do it very quickly and decide which way of treatment you want to go, depending whether it's an ischemic or a hemorrhagic stroke. Here, for example, you can see that area of hypodensity and effacement of the sulci, indicating that this is an ischemic stroke. On the other hand, here you can see this hyperdense lesion there, with a complete effacement of all the sulci, which means that this is a hemorrhagic stroke as well. So CT is very good for this kind of a quick diagnosis of which way you want the treatment to go. Moving on, here's a patient with optic atrophy in the right eye, but if you look closely, you can see not just temporal pallor of the left disc, but you can also see some amount of nasal pallor. This is a bow tie optic atrophy, and that's very typical of chiasmal lesions, and this patient had a pituitary adenoma. I put these pictures up because you can very clearly see all the three views, the axial, the coronal, and the sagittal sections of the brain, as well as T1 images where the fluid, like the vitreous, is dark, and T2 images where the fluid appears bright. And here you can see the pituitary adenoma with suprasellar extension pressing the chiasm. One interesting thing is there, you can see on T1, you can see a little hyperintensity lower. There are very few things which are hyperintense on T1. So these would be several things here, but most importantly, in this particular case, it happens to be a bleeding into the tumor. So this is an example of a pituitary apoplexy. So T1 images, to summarize, shows anatomy very, very well. And how do we make out T1? Because the fluid appears dark. Moving on, here is the patient with right optic neuritis. The T1 weighted image shows an iso-intense optic nerve, but on a T2, you can clearly see the hyperintense optic nerve. So T2 is very, very useful for showing pathology, as in this case with optic neuritis. In the same patient, after injection of contrast, first of all, this is a T1 weighted image because, as you can see, the vitreous is dark, and we use contrast on T1 images only. And you can see that area in the yellow dots where the nerve is enhancing with gadolinium. So contrast, of course, shows pathology very well. Remember, it looks like T1, but you can see these little dots representing blood vessels. That will give you a quick clue that you're looking at a contrast image. Also, the extraocular muscles look very bright as well. So same patient, you saw that iso-intense optic nerve. But you can see on T1, the fat is hyperintense. But on T2 also, in the kind of acquisitions we take nowadays, the fat starts to look bright as well. So it's not very clearly seen, the hyperintensity of the optic nerve on T2 images. But if you can dim the fat that you see here, you suppress it, then you can see the nerve very, very clearly. These kinds of protocols ending with the letters IR, as you can see there, stand for inversion recovery sequences. So this is a spur image, which is a fat suppression. So that's convenient to show orbital pathology and also skull-base lesions. Here, another suppression image. We'd like to suppress water in this case. This looks like an almost normal looking T2 weighted image, but if you suppress the ventricles fluid, CSF, you can see a periventricular MS plaque. So flare images, once again ending with IR, this is fluid attenuation inversion recovery, suppresses CSF, shows brain pathology very well. In optic neuritis, don't forget, which sometimes we need to take recourse to spinal sequences as well, apart from looking at the brain and the optic nerves. Here you can see small segments of involvement in the spinal cord, suggesting multiple sclerosis. Conversely, you can see an extremely long segment involvement here in neuromyelitis optica. That also helps you to differentiate between the two conditions. This one is called LETM, a longitudinal extensive transverse myelitis. Now coming to PCA infarct, let me show you some pictures here. So on axial flare, this patient, you can see bilateral occipital lobe lesions. One side is looking hyperintense, the side on the right is showing mixed signals and also looking a little hyperintense. So here you can see, if you do diffusion weighted image, you can see clearly differences between the two sides. Decreased diffusion, looking brighter, indicating acute infarction, and increased diffusion, indicating an old infarct as well. So diffusion weighted images are useful in early diagnosis of stroke. This is a patient with a 6th nerve palsy, and as you can see, she has aneurysm here. So always in cranial nerve palsies, you need to do an MR angiogram as well. This shows a giant intracavernous carotid aneurysm. So all cranial nerve palsies, hemifacial spasms, any vascular lesions, don't forget to do this. In this patient with papilledema, don't forget to first check the blood pressure. But classically in IIH, you see widened perioptic spaces, the empty cellar, and don't forget to do an MR venogram where you can see hyperplasia of the sinuses, dural venous sinuses. So that's important for MRI plus MRV in IIH, presumed IIH cases. My last sequence is an extremely bright T2 weighted like looking picture. This is called a CIS or a fiesta image. You can see the cranial nerves in the subarachnoid space. See the right 7th nerve, and you can see the left one there. But next to that, that's the 7th nerve, and you can see this anomalous blood vessel loop. So this patient had a left hemifacial spasm. So these are SSFP sequences going by different names according to different machines, but they're very useful in looking at cisternal segments of the cranial nerves. So in conclusion, choose the appropriate modality. CT has its uses in orbit trauma, acute stroke. MRI is useful for soft tissue imaging. It's important for us also to be familiar with MR sequences and protocols, and always talk to your radiologist before sending the patient. Thank you very much.
Thank you, Dr. Navin, for setting the tone there for dealing with the most important investigation in